Buongiorno, voglio ringraziare Andrea e la Fondazione IBSA per l'invitazione a questo evento molto importante. I enjoyed a lot, siamo vicini amici fra molto tempo. I have to correct a little bit because I'm an old man in the meantime. I'm no more chairman of the psychosomatic division. I was in between chairman of the obstetrics and gynecology department, and now I'm retired. But I'm very much still interested into sexual medicine. And for the moment, we are trying to build up at our institution an interdisciplinary consultation and center for sexual medicine. And what I'm going to talk about today is part of this very practical work. So, if the question is sex still important in the elderly? This is a challenge because it's so difficult to know, first of all, what is elderly? And second, what are the changes which we are observing? What should be measured? Behavior, experience, dysfunction, satisfaction. How should we measure? What type of study should be used? Possibly, of course, prospective, which is very expensive, comparative, cross-sectional, which is less expensive, but has a lot of possible confounders and biases. So, what do studies actually say? Let me very briefly give you a little bit an empirical overview. Does sex stop at a certain age? Does sexual activity decrease with age? Do sexual dysfunctions increase with age? And what are the most frequent dysfunctions? I know from this functional standpoint, we know really a lot. We know that there is no age limit, but a huge variation. It's not, there are people who really stop having sex, and there are people who have an increased frequency of sexual activity. So this is the first statement. There is no upper age limit and a huge variation. Second, there is certainly, if you take the mean, an age-related decline on average with this large variance. Age-related decrease in sexual activity. It seems, by the way, that the decline starts at age 30 and is accentuated around age 50. Interesting enough, probably also in both genders, in women more than in men. The dysfunctions, what we call the dysfunctions, and I'm coming back on this, certainly also increase with age, and again with a large variance. We know that the most frequent dysfunctions in men are erectile dysfunction, premature ejaculation, followed by low desire. And we know that the most frequent dysfunctions in women are what has been called HSTD, what is now called a combined disorder of desire and arousal, followed by pain disorders. Now, that's very simple. I mean, age, things get worse. But the other important finding is, of course, how important are these changes for the elderly? And how often do they seek help? Because quite obviously we apply a model which has been developed in younger people. So is it justified to apply this model? And I think it is clear in most of the study that the subjectively reported distress in relation to so-called sexual dysfunction declines with age. People have more dysfunction, but they are less distressed by it. What does it mean? It means it's less important. And this is also reflected in the fact that both genders do rarely seek professional help. Now, of course, this statement may have two reasons. One, it's not so important, and the other, of course, are the cultural barriers to talk about sex in older age. So we do not know really about this, but certainly there are these two aspects coming together which lead to the fact that elderly people rarely come to a sexual health clinic. I would like to focus very much on the clinical approach which we are trying to realize at our institution. And there we have to be aware that there are special conditions and characteristics of sexuality of elderly individuals or elderly couples. On one hand, we have, of course, the real medical issue of an increased physical morbidity frequently, an increased psychological morbidity. Very often there are no isolated dysfunctions, but high comorbidity. The dysfunctions may be in both men and women, or in only one of the two. And what is important, there may be an important discrepancy in the personal development of the sexuality. I'm coming back to this in a moment. The other issue, of course, is with respect to communication in the consultation. Elderly couples have very often feelings of shame, feelings of inferiority, social stigma. Should they have sex? Is that still normal, their needs? There is an insecurity. And very important, there is a lack of words and language. How do you really talk about sex? And again, as I mentioned before, there is a high degree of inter-individual variation, and there is not the typical older patient, man or woman, with sexual problems. So, to understand the background of this consultation, I have tried to find out how is society going, how is society dealing with sexuality in the elderly. And I had the impression that there are more or less 4 different approaches. One is the flaccid penis and dry vagina discourse. This is very much on physical function. It's about medical possibilities, and it's clearly the medical perspective which has become more important in recent years due to the PD5 inhibitors on the male side, but also due to research into drugs for female after menopause and around menopause. Then there is another discourse. It's the gentle post-passion sensual sex discourse. It's about focus on changing sexual needs, new definitions of sexuality and sensuality. It's more what I would call the rehabilitation perspective. Then you have the third one, which is actually a double issue, and this is about the fulfillment of sex at older age discourse. This is, of course, the crucible approach where there is a focus on self-experience. You have learned a lot about sex, and only in older age you can really develop your full sexual experience. It's about development, partner-validated and self-validated identity and intimacy. And this is the new systemic sex therapy perspective. And then there is another solution which usually does not come into the clinic, not directly, but very indirectly. And this is what I would call the rejuvenation by younger partners. We do know that it is good for men to have a younger partner, older men to have a younger partner. They improve their sexual pleasure, but the same is also true for women. Women who have younger men as partners improve their sexual pleasure. It's interesting, I was yesterday in Turandot by Puccini, and Puccini coined the phrase that he was looking for una vagina fresca. So, but this is not an issue of our clinical practice, but this is what happens, of course, outside, but can create a lot of problems which come into the... So, if we are trying to understand what do people really suffer from, so I think basically in all the consultations, it's a degree of discrepancy between my sexual needs and wishes, what do I want, how important is sex for me, and my sexual reality. What do I experience? What is my interpretation of my experience? And this sort of relationship is modified by our inner comparator. We have some sort of unconscious or semi-conscious or even conscious inner comparator measure, which is either that I compare it with my previous experiences of pleasure, joy, my previous level of function, or I compare it with the sexual ideal, sex and love, sexual norm, conformity model, or there is the comparator with the partner's wishes and requests, which is, of course, then a different issue. And I think in each individual patient, we have to understand where does the suffering really come from? So how big is the discrepancy between what I want and what I get, and what is the inner comparator? Because some part of psychotherapy is really working on the left side, looking into the needs, and also working on the comparator, which may have an impact on the suffering. So, as you may know, we are trying to put in the biopsychosocial model in the sexological care of the elderly individual and couple. And what does that mean, actually? We think there are 4 axes. One is the female with her biological, psychological, and sociocultural characteristics, the male with the same. We have the pattern of communication and interaction. This is axis 3, the couple dynamics, and we have the timeline, which is sort of what happened before, what is happening now, and what is maintaining the disorder. So this is the theoretical model of the consultation. Very briefly, if you look into the elderly women, what are the typical biomedical issues? Postmenopause, estrogen-androgen deficiency, drugs, cardiovascular hypertension, depression, very frequently, anxiety disorder, rheumatic disease, metabolic syndrome, diabetes, and even cancer. What are the psychological sort of challenges in the elderly women? There are negative expectations, performance anxiety, personality characteristics, negative story, a separation, trauma. People have been vulnerable. There is vulnerability, loss of self-esteem, a lot of problems with the body image, and loss of autonomy and dependence. And then the sociocultural is very important because we do have a male-dominated model of sexuality. There is this famous double standard of aging. Gray hair man is still attractive, gray hair woman may not be so attractive, etc. There is a rigid role model. There is a lack of learning possibilities for elder women, and there are the norms and education. The elderly man is also quite troubled, maybe by biomedical problems, cardiovascular, prostatic, brain, diabetes, etc. The psychological issues is again, that there are negative expectations, especially performance anxiety, as we have heard. There are these negative stories, loss of self-esteem, and also professional challenges. They lose their position, they lose their autonomy, they become dependent. And finally, the sociocultural issue that there are a lot of myths about male sexuality around, which does not correspond to the older male. Men always want and can have sex, and there is this fixation of the standard model of sex, which is you stimulate each other, you have penetration, you have orgasm, and then this is the scenario. So all these factors, of course, the couples bring into the consultation, and again, very often they take a lot of drugs. I can't go in all these issues, but what we have to be aware of: does the drug have an effect on the mucosal membranes? Does it have an effect on the flow to the genitalia? Does it have an effect on the innervation of genitalia? Does it have an endocrine effect on hormones, estrogen, androgen, prolactin? And does it have an effect on CNS? This is just also for the residents and for the people who are trained to have this sort of orientation and list. Now, the couple dynamics, very briefly, of course, this is a huge subject. We understand that there are two individuals with their wishes, their fears, their temperament, their potencies and valences. And then you have the so-called centripetal factors, which bring them together: bonding, trust, affiliation, stability. But you have also centrifugal issues always in all couples, which is about autonomy for myself, freedom, independence, and change. So the actual situation in the couple is always a balance between these two forces, bringing them together and separating them. So it's about sameness and difference. Very briefly, the main issues which I think should be integrated into couple analysis. What is about bonding, between bonding and freedom, between stability and development, and between give and take. And of course, whether these issues can be really discussed, it depends on the introspection and communication between the couple. And here very often each consultation can help. There are risk factors, very important risk factors: habituation and routine, loss of attractivity. What is the aestheticism regarding older bodies? Very, very important. Fear of instability, conflicts. There is this desynchronization, differences in temperament. A lot of issues are jealousy, third-party involvement, conflict about values, collusions, and communication disorders. But there are also resources. I mean, if you have been together for 30 years, you have a degree of intimacy, you have experience, you have shared life story, children together, sympathy, solidarity, diminution of stress because you know each other. There is maybe more patience, and there are new compensatory activities. So I think we all agree that in sexual medicine we have to focus very much not only on deficits but also on resources. So I come to the end. So the first step is, let's find out what is the desired sexuality versus the real sexuality, which phases of the sexual response, and we are still applying the classical concept, are affected, and what is the effect on self-esteem and identity and relationship. And then we try to work out, together with the couple, the biomedical factors, the psychological factors, and the social cultural factors, which have an impact also on the couple dynamics. We very often then try to bring people together to find out what are they expecting? What does the status quo look like? What are possible advantages of the actual situation? What are the benefit and risk if the sexual problem disappears? This is a classical systemic intervention. What exactly should change? What should stay the same? What can they do themselves to help? What must be accepted by him or her? And maybe replacing, these 100% objectives by stepwise approaches. 50% would be fine. So this is about rehabilitation instead of therapy. Now, I think we have found that there are 4 groups of patients, more or less. There is the group where the focus is very much on loss of function, erectile dysfunction, premature ejaculation, newly observed pain, arousal disorder. So these couples expect restoration of function. There are some couples where the focus is also very much on loss of function, for example, after breast cancer or certain prostate cancer, where you do have the reality of an irreversible loss of function. So this is much more about rehabilitation. But there are a considerable number of elderly people where the focus is really on insecurity, about meaning and change of inner needs. What is going on in my body and what is going on in my mind? Is this normal? So they need mainly psychoeducation. And then there is the more couple-related issues, that there is a discrepancy in sexual development. There is some alienation and distance, where the focus is very much on couple therapy. So I'm coming to the end. So what is the therapeutic plan, which should be individualized? Of course, it is very important, the classical psychoeducation, permission giving and limited information, impact of aging on sexuality, risk and advantages, resources and advantages, information about how other people experience, and very important, try to make people understand what is the difference between men and women, so that they can better understand their different reactions. So this is basic counseling, information, and education. A lot of myths have to be corrected, which I've been talking about before, and this has an important impact because a lot of information about sex comes from the internet, and these are misinformation and misconcepts. Sex is for young bodies only, and a very important issue is that people think sex toys are pervert or are only for perverts or for people who are sexually sick. The contrary is true. It is important really to encourage them to use erotic material or also use sex toys, vibrators, dildos, etc. And then we have of course, a considerable number of drugs at our disposition for male and female. I'm not going into this, but because this is a chapter of its own, where indeed we can have some biomedical interventions. We do have the modified sex therapy with sex toys, video, sensate, focus, and body awareness. And we do have always integrated somehow the communication training among the couple. So this is sort of the concept: basic counseling, correcting myths, looking into biomedical interventions, looking into modified sex therapy and couple therapy. And then I think the individual or the couple has to decide which way they want to go. Sorry. So I think that was what I wanted to say to you. Thank you.
Thank you.